I think there are more people to join, and I hope they will join in another couple of minutes. Today we are going to talk about a very important topic, which usually will not be dealt in any other classes. And this is about rehabilitation, which is a very important aspect of palliative care also. So we have Dr. Ramamoorthy with us. Dr. Ramamoorthy is the professor and the HOD of Physical Medicine and Rehabilitation at the PSC Medical College, Coimbatore. And he has a lot of experience in this particular field. And I have personally seen how his skills and his knowledge when he did his 6-week certificate course in training palliative medicine with us long back. And he has, there are MD students in his department. In addition to that, he has published articles and presented in conferences. And he runs specialty clinics in his hospital, diabetic food clinic, and a few other specialty clinics also. So the module on rehabilitation is also written by Dr. Ramamoorthy. I welcome Dr. Ramamoorthy, sir, and it's over to you, sir.
Good evening, everyone. Thanks for the nice introduction, Dr. Sunil sir. If somebody wants to learn palliative medicine, they must learn from Dr. Sunil Kumar. This is my observation when I did my 6 weeks program in tips. Whoever wants to learn palliative care medicine, they have to learn from Dr. Sunil Kumar. So at the outset, I thank Dr. Sunil Kumar, Additional Director, Trivandrum Institute of Palliative Sciences, for giving me this opportunity to talk to the palliative care physician on 3 topics. One is management of osteoarthritis knee, and the other 2 are rehabilitation of spinal cord injury and rehabilitation of stroke. I'm given 2 hours time, 120 minutes time. So, I'm going to discuss each topic for 30 to 35 minutes time. The next 5 minutes, we can have a discussion. We can have a discussion once that particular topic is over. If you want, we can break in between for 5 minutes. With this introduction, I will start my first topic, comprehensive and holistic approach to the management of osteoarthritis knee. Next, please. This is the profile of our medical college. Next. I welcome every one of you for this presentation. This is my favorite slide. All my presentation will have this slide as a first slide. The word teach is reflecting in the glass kept below as learn. In Latin, to teach means to learn twice. This osteoarthritis I am practicing for the past 23 years. But still, for this presentation, I spent some time to update my knowledge. So a teacher is a learner throughout his career. The day a teacher closes his book, he ceases to be a teacher or a doctor. Next. So I am going to discuss the first topic in these headings. We'll have a case history, symptoms, assessment, science, pain assessment, radiological assessment, diagnosis, histology and pathology, clinical features, complications, and next, management, medical management, orthosis, and surgical management. Right, next. A 55 years old Mrs. Malini presented with right knee pain for the past 6 months. She has difficulty to walk long distances, to climb up staircase, to sit cross-legged, and to squat on Indian toilet. She says her right knee is stiff and make noise when she walks. She is obese and her weight is 93 kg. Her body mass index is 34. She has no other comorbidities. How will you manage her pain? You can type in the chat box. Actually, whenever we get a case of knee pain, when we discuss with the students, we discuss the differential diagnosis. What are the causes for knee pain? For want of time, we take this case as a osteoarthritis knee. So this is a case of osteoarthritis knee. How are you going to manage here? You can type in the chat box. Reduce the weight, which is good. Prescribe analgesic, yes, that's what everybody will do, good. Both are good answers, reducing the weight and prescribe analgesic and along with the exercises, good. Physiotherapy. Right. Next, please. So we have seen the case history. Now we'll see the symptoms. Next. So in the history, the patient has given the following are her symptoms: knee pain, difficult to walk, difficult to climb upstairs, difficult to sit cross-legged, and difficult to squat. And she feels her knee is stiff and make noise, and she is obese. Next. So symptoms you have seen, then assessment. Next. So whenever we receive a patient, after eliciting the history, we assess them. So how are we going to assess a patient with osteoarthritis knee? Next. So clinical examination. Next. You have to expose the joint area. You have to see the knee joint. Next. So you have to look for quadriceps muscle wasting. You have to examine and assess the muscle power of the quadriceps. Look for crepitus, feel for the crepitus. You have to elicit pain on the medial knee joint line. There will be restricted range of motion in the knee and there may be effusion. So the signs. Next. And in the left knee, if you carefully watch, you can observe the quadriceps wasting. That means it's a long-standing problem. Next. So whenever you write a case sheet for osteoarthritis knee, you have to mention what is the weight of the patient, what is the BMI. Then you have to mention the quadriceps girth, what is the circumference of the quadriceps, what is the strength of the quadriceps, the MRC grading out of 5, what is the quadriceps power. Because after 4 weeks, after 6 weeks, when you reassess, you have to see the improvement in the quadriceps girth as well as in the quadriceps strength. Next. So you feel the joint line. In the picture, the lines drawn, what you see here is the lower end of the femur. The curved line is the lower end of the femur and the flat line is the upper end of the tibia. The horizontal 3 marks represent the joint line tenderness, medial joint line tenderness. And the vertical 3 star represents the medial collateral ligament. Usually the medial collateral ligament will be relaxed in the osteoarthritis knee. Next. Then assessment of pain. Next. As a palliative care physician, you are on masters in the assessment of pain. You all know the pain is a purely subjective feeling. So you have to get the pain of the patient through the numerical pain rating scale. There are several scales. What we practice is a numerical pain rating scale. 0, no pain. 1, 2, 3, 4, mild pain. 5, 6, moderate pain. 7, 6, 8, 9, 10, severe pain. Next. Then functional assessment. So in the functional assessment, we have a pain score called WOMAC pain score. That is Western Ontario and McMaster University's osteoarthritis index, WOMAC score. There are three items. There are three areas. One, pain, then stiffness, then physical function. In the pain, there are 5 items. Stiffness, there are 2 items. The physical function, there are 17 items. There are totally 24 items. Each item can be graded from 0 to 4. So 24 items. So the minimum score will be 0 and the maximum score will be 96. So after assessing through the WOMAC pain score, you know the clinical condition of the knee. Next. Several times we come across patients with knee pain. They also have the meniscal injury. Though there is no injury, there will be mucoid degeneration of the meniscus. So always better in a patient with the knee pain, determine the meniscus also through the Murray's test. Next. So investigations. Next. So generally we order for the X-ray of the AP view and lateral view. Lateral view may not contribute much, so we take skyline view. AP view to see the tibiofemoral joint, skyline view to see the patellofemoral joints. Next. So there are 4 radiological features of osteoarthritis knee. 1, reduced joint space, then sclerosis, then osteophyte, then synovial cyst, subchondral cyst. This is the articular cartilage. Since the articular cartilage has less calcium content, it is not visualized in X-ray. It looks like an empty joint space. You can see in the medial side, it is almost nil. The medial femoral condyle is hitting on the tibial condyle. Okay. And in this picture, you can see the osteophytes here, osteophytes. So the radiological features of osteoarthritis are joint space narrowing, subchondral cyst, osteophyte formation, and subchondral sclerosis. We are going to see in depth why this thing occur in the pathology. Next. So after taking the X-ray, we read the X-ray through Pellegrin-Florence classification. There are 4 grades, grade 1, 2, 3, 4. In the bottom, I have written a mnemonic, DPTM. D stands for doubtful narrowing of joint space. P stands for possible narrowing of joint space. And the D stands for definite narrowing of joint space. M stands for marked narrowing of joint space, grade 4. Next. And this is the doubtful, possible, definite, and this is more marked narrowing of the joint space. Next. Okay. So we have seen the history, we have seen this, discussed the symptoms, we have assessed the pain, and we have made a radiological investigation also. Now, what's the diagnosis? Next. Next. So, according to the American College of Rheumatology, the criteria to say osteoarthritis knee, next please. The patient must have knee pain plus another 3 of the 6 following characteristics. Age more than 50 years, morning stiffness around 30 minutes, no palpable warmth. When the patient gets warm, that means it's an inflammatory arthritis, some other secondary osteoarthritis. There must be crepitus, bony enlargement, and bony tenderness. Next. 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 Okay. On the left side picture, you can see the lower end of the femur and the upper end of the tibia lined by the articular cartilage. The violet color is the articular cartilage. On the right side, osteoarthritis knee with the damage of the articular cartilage. Next. In osteoarthritis knee, the anatomical structure involved is articular cartilage. So whenever we discuss a patient with pain, we always discuss what is the anatomical structure involved. In the case of periarthritis shoulder, the anatomical structure involved is capsule of the shoulder joint. In the case of plantar fasciitis, the anatomical structure involved is the plantar aponeurosis. Similarly, in osteoarthritis knee, the anatomical structure involved is articular cartilage. Next. So cartilage is a connective tissue. It is found in the ends of the bones in the joint. It acts like a shock absorber. And the hyaline cartilage is the cartilage of the synovial joint. Next. And this is the histology of the hyaline cartilage. In the microscopic view, outer there is a perichondrium. The perichondrium consists of fibroblast, chondroblast, and type 1 collagen. And the innermost layer is a chondrogenic layer. That means from the innermost layer, chondrocytes are generated. Deeper to the perichondrium, there's an extracellular matrix. In the extracellular matrix, you will have chondrocytes, and you have type 2 collagen and proteoglycan. Next, please. So deeper to the perichondrium, there's an extracellular matrix that contains chondrocytes, type 2 collagen, proteoglycan. Next. So chondrocytes are the cells of the hyaline cartilage. They are embedded in the extracellular matrix. They produce the collagen fibers and proteoglycan. Next. These chondrocytes, deeper to the perichondrium, they are situated inside the lacuna. It's called chondrocyte lacuna. Next. So in the extracellular matrix, we have two types of things. One is the collagen type 2, and then another one is proteoglycan. Next. This is the structure of the collagen. It is a protein structure because it is made up of 3 amino acids, namely proline, hydroxyproline, and glycine. The collagen molecule is formed like a triple helix. Next. And this is the arrangement of the type 2 collagen in the articular cartilage. You presume this is the lower end of the femur. It is covered by the hyaline articular cartilage. And the articular end, the type 2 collagen is arranged like in a horizontal form to resist the shearing force. Here you have the tibial articular end. This is femoral articular end. To resist the shearing force, the collagen 2 fibers are arranged in a horizontal line. Close to the bone, the collagen fibers are arranged in a vertical form to resist the compressive forces. In between, they are randomly arranged. Next. Next. Third thing found in the extracellular matrix is the proteoglycan. Next. So the proteoglycan consists of a hyaluronic acid, a non-branching structure. It's a non-glycated glycoprotein. It acts like a scaffolding to hold the contracting sulfate together. Next. So hyaluronic acid is a chain-like structure, non-sulfated glucosaminoglycan. It's a scaffold structure to hold contracting sulfate. Next. And this is contracting sulfate. It is sugar made up of disaccharides, alternate layers of glucuronic acid and N-acetyl galactosamine. This is the contracting sulfate. You may be surprised why I'm talking all these things. Is it necessary to know the histology and pathology? Yes, it is, because in the management, we are going to supplement collagen. We are going to give contracting sulfate. So you must know what is this and what is the role of the collagen and contracting sulfate in the articular cartilage. Next. So this is a normal knee joint, lower end of the femur covered by the pink color articular cartilage, upper end of the tibia covered by the articular cartilage. This is a synovial space with the synovial fluid. Next. Pathogenesis. Next. Okay. So when I studied medicine in the early 90s, we studied pathology from the book Boyd's textbook of pathology. The preface, the author writes, "Assess your pathology, so is your practice." If you know the pathology of any disease, you can tell the course of the disease, you can predict the outcome of the disease. So pathology of the disease is very much important. Next. Okay. I am going to explain the cardinal features we see in the osteoarthritis: loose bodies, crepitus, pain, synovial cyst, osteophytes, stiffness, restricted range of motion, and sclerosis. Next. Okay. The first thing that happened to the articular cartilage is the damage to the articular cartilage. My grandfather lived up to 90 years. That time also I was practicing medicine. He has never complained of osteoarthritis. He lived up to 90 years. Okay. So that means not necessary all the people will have osteoarthritis knee. Who will get osteoarthritis for some reasons in any injury to the articular cartilage, either single large event or repeated microtrauma, that there will be damage. There will be damage to the normal articular cartilage with normal loading. Second thing, in my practice, I have seen 22 years old girl with osteoarthritis knee. That means her articular cartilage is not formed well. It's a genetic anomaly in articular production, in cartilage production, and inborn errors of cartilage metabolism. So there is a failure of the abnormal cartilage under normal joint loading. Third category, Ehlers-Danlos syndrome, where there is hypermobility, failure of the normal cartilage under abnormal loading. For some reasons, there will be destruction of the articular cartilage. That is the initiating thing. Next. Once injury occurs to the articular cartilage, the chondrocyte responds. The chondrocytes proliferate and secrete collagen 2 and proteoglycans and protease enzymes. Okay. Not only that, it also secretes inflammatory mediators that mediate secondary inflammatory changes in the synovium. As a result, there will be more synovial fluid, and the water content of the matrix will increases and the concentration of proteoglycan decreases. In the late osteoarthritis, repetitive injury and chronic inflammation lead to chondrocyte dropout. Next. Then damage to the collagen. So after the injury to the articular cartilage, the chondrocyte responded by producing more collagen and more proteoglycan. Due to injury, the collagen type 2 is degraded by the enzyme called metalloproteinases. The normally horizontally arranged collagen type 2 fibers in the superficial zone are cleaved, yielding fissure and clumps in the articular surface, through which the synovial fluid will creep into the subchondral bone that forms the synovial plug. You can see in this picture, there's a cracks in the articular cartilage through which the synovial fluid will sweep in. Next. Then the other substance in the extracellular matrix, proteoglycans. Although chondrocytes continuously synthesize and secrete proteoglycans during disease progression, degradation ultimately exceeds synthesis and the composition of proteoglycan changes. Eventually, chondrocytes die and there is a full thickness portion of cartilage are sloughed. Next. And this is the microscopic view of the damaged articular cartilage. There are all filtrate, there are many fibrils. Next. These dislodged pieces of cartilage and the subchondral bone tumble into the joint, forming the loose bodies called joint mice. Next. The loose flakes of cartilage incite synovial inflammation and thickening of the capsule, leading to the deformity and stiffness of the joints. Next. Stimulation of the joint receptors in the subchondral bone. When the articular cartilages are damaged, the subchondral bones are exposed. The nociceptive receptors in the subchondral bones are stimulated. That is why the patient gets pain. Next. The exposed subchondral bone plate becomes the new articular surface, and friction with the opposing surface smooths, varnishes the exposed bone, giving it the appearance of polished ivory. Lack of cartilage means direct contact between the bony prominence of the femoral condyle and tibial condyle that results in crepitus. Next. There is rebuttressing and sclerosing of the underlying cancer bone. The femoral condyle and the tibial condyle will be hitting again each other. Because of the loading, there will be sclerosis in the tibial condyle. Next. Mushroom-shaped osteophytes, bony outflow will also develop at the margins of the articular surface, and they are capped by fibrocartilage and chiral cartilage gradually. Next. So impaction of the osteophytes with the normal joint structure during movement may produce pain. So the causes for pain in osteoarthritis are two. Already I told you, when the chiral cartilage is damaged, the nociceptive receptors in the subchondral bone are stimulated, that may produce pain. Here, the osteophyte may stuck between this joint structure, that may also produce pain. Next. The combination of joint pain, stiffness, and effusion will result in limitation of the range of movement. Next. So the injury started with articular cartilage, but it damaged all the structures in the joint, namely bone, capsule, synovium, nearby muscle, ligaments, and bursae. Next. Here you can see there is a crack in the articular cartilage. Next. You can see the synovial fluid dripping into the cracks. Next. And there's a formation of the synovial cyst. Next. There's almost bone damage, formation of osteophytes, and broadening of the bones. Next. Okay, you have seen histology pathology. Next. The clinical features: the patient will complain of pain, crepitus, stiffness, and restricted range of movement. That is why she was not able to climb the staircase. She was not able to squat. She was not able to sit cross-legged. Next. Next. The complications next are next. There may be formation of the bracket cyst and loose bodies. Next. Now we have assessed the patient. We have discussed the pathology. Now we are going to manage the patient. Next. So the management of osteoarthritis knee, we have non-pharmacological management and education of the patient about the condition, giving importance to the weight loss, physiotherapy, occupational therapy, exercises, adaptive devices, assistive devices, appropriate footwear modification, bracing, and joint protection techniques. Next. Joint protection techniques. Next. So we read orthopedics in a book called APLAY. The author writes like this: if you have the opportunity to sit, don't stand. If you have the opportunity to stand, don't walk. If you have the opportunity to walk, don't run. These are the measures to protect your knee joint cartilage, articular cartilage. Next. The joint protection techniques are doing everyday activities and work with little strain. Pacing is very, very important between the activities. Avoid squatting, use western toilet, avoid sitting cross-legged, avoid prolonged standing, don't lift heavy weights. Next. Then medical management, pain management. Next. Non-steroidal anti-inflammatory drug. As a palliative care physician, you must have a sound knowledge of pharmacology. Then you can play with the drugs. Okay. The NSAIDs are classified into non-selective COX-2 inhibitor, preferential COX-2 inhibitor, selective COX-2 inhibitor, and analgesic antipyretic. In the non-selective COX-2 inhibitor, we have salicylates, propionic acid derivative, phenamate, enoic acid derivative, citric acid derivative, pyrosolene derivative. Any drug you can choose. You can follow the WHO analgesic ladder. Okay. If I go through 10 prescriptions, 8 will have diclofenac or cilofenac these days. But you can choose any drug justification. Next. Then the non-steroidal anti-inflammatory drug alone may not be sufficient. At one point of time, the patient may have acidity, gastric ulcer. So we have to prescribe other drugs also. We have chondroprotective drugs, glucosamine and contractile sulfate. Glucosamine stimulate chondrocytes, so there will be secretion of the proteoglycans and hyaluronic acid. Contractile sulfate inhibit the degrading enzymes. The recommended dose is 1,500 milligram and 1,200 milligram. Next. So the glucosamine sulfate, contractile sulfate are available in the name Polagos. Next. How does it work? The contractile sulfate, they stimulate the synthesis of cartilage. They reduce the cartilage destruction by matrix metalloproteinase enzymes. They also reduce inflammation by decreasing the inflammatory markers. It's a wonderful drug. Next. So collagen also available, type 2 collagen also available. You can also supplement. Next. So We have a disease-modifying drug called diacerine. It's a class of anthraquinone. It works by inhibiting the interleukin-1 beta. Disease-modifying drug diacerine. Next. The hyaluronic acid is also available in two forms, oral form as well as injection form. Next. It's an injection form. Next. You can give intra-articular injection also. This I used to give triamcinolone 40 milligram. It's a very easy technique. If you work with an orthopedic surgeon or a physiatrist, wherever you practice, you just observe two cases, how he or she gives intra-articular injection. You have to identify patella, then you identify the ligamentum patella. On either side of the ligamentum patella, you can infuse this drug. It's a very simple way. It's hardly, it will take 3 minutes time. And it's an anti-inflammatory. The patient will respond very well. Triamcinolone. Next. Then the PRP, protein-rich plasma also, we have tried. It's a concentrated platelets. It helps to repair the damaged tissue. Next. So far we have discussed the management through medicines. We discussed non-steroidal anti-inflammatory drug. We discussed the supplementation of collagen. We discussed the supplementation of hyaluronic acid oral or intra-articular. Then we discussed the intra-articular steroids also. Then the platelet injection. Then orthotic management. Next. So the braces offer external support. Next. Next. And this is the G2 brace. The Roman letter 2 stands for generation. Second generation brace. This will correct the, actually with the radiological grading 4, the patient will develop varus deformity. This G2 brace will correct the varus deformity. Quite expensive, 30,000 rupees. Next. Also, you can prescribe footwear with lateral wedge. So the patient has medial compartment osteoarthritis knee. For this patient, if you raise his lateral side of the foot, this will wide open. So there is one form of offloading. So footwear with lateral wedge. Next. So you can provide a walking cane also. Suppose if I have an osteoarthritis knee on my right side, I have to hold the walking cane on the left hand. When I walk, I take my left foot first, then I take my right foot as well the can forward. So I bear the weight of my body on the can, not on the right side of the leg. Next. And physiotherapy management, very important. We have to strengthen, next please. We have to strengthen the adjacent muscles. Next. We have to strengthen the quadriceps. We have measured the girth of the quadriceps. Also, we have assessed the muscle power strength. So we have to strengthen the quadriceps. Next. We have to strengthen the hamstring as well. Then we have to, next please, we have to strengthen the hip muscles also. The hip extensor, namely gluteus maximus. Next. Hip abductor, namely gluteus medius and minimus. And next, we have to stretch the hamstring as well quadriceps. Next. Then electrotherapy. We have several electrotherapy equipments to relieve the pain. Next. We commonly use wax therapy, ultrasound, IFT, shortwave therapy, laser and TENS. The physiological effects of these modalities include deep heating, increased blood flow, and reduced muscle spasm and pain relief. Next. These are some of the equipments, wax cloth and ultrasound. Next. Then surgical management. Next. Under surgical management, we have arthroscopy, osteostomy, and joint replacement surgery. Next. Arthroscopy. It helps for the debridement. Next. So through arthroscopy, debridement will be done. There will be cleaning out of the joint, all debris and loose fragments. If successful, it will release the symptoms from 6 months to 2 years. Next. This is the removal of the loose bodies through arthroscopy. Next. And proximal tibial osteotomy. Usually, the osteoarthritis will be on the medial compartment, so there will be varus deformity. To correct this, they make a wedge of bone from the lateral side of the upper tibia. Then a stable or plate and screw is fixed. The proximal tibial osteotomy will also buy some time before the total knee replacement. Next. So this is the area they have removed the bone, and this is the stapler they have put. Now they have corrected the ankle. The varus deformity is corrected. Next. Then the total knee replacement with patients with severe knee pain. NPR, numerical pain rating scale 10. Radiological classification grade 4. Pain for years. They are the fit candidates for total knee replacement. The ends of the femur, tibia, and patella are shaped to accept the artificial surfaces. The end result is all moving surfaces of the knee are metal against plastic. Next. Next. And this is the ABC of management of osteoarthritis knee. A stands for analgesic and arthroscopic debridement. B stands for brace, second generation brace. C stands for cane, walking cane. D stands for disease modifying drug, diacerin. E stands for exercise therapy and electrotherapy. F stands for footwear modification, lateral wedge. G stands for the contraprotective drug, glucose sulfate. H stands for synovial hyaluronic acid supplementation. I stands for intraarticular steroid. J stands for joint replacement surgery. Okay, this is my another favorite slide. I hear and I forget. I see and I remember. I do and I understand. So with this, I have completed the first topic, the given time. We will discuss for 5 minutes. Almost 40 minutes gone. We can discuss for 5 minutes.
Sir, how effective is it in giving chondroitin sulfate orally? Won't it get digested once we give it, and is it absorbed as such?
Sir, my patients are taking for 6 to 9 months without any side effects. And there is a significant improvement in the pain. So boldly you can prescribe whatever area you are, in whichever state you are practicing, it must be available. You can boldly prescribe. You can give for at least 6 to 9 months. The recommended dosage is 1500 milligram. Usually it is available 750. Then you have to give a BD dose. It is available in Rejoint name also. Rejoint 750, Rejoint plus you can give BD. OD, Rejoint plus OD, Rejoint BD.
So what are the duration of other drugs like diacerin, hyaluronic acid?
I give for 3 months the hyaluronic acid oral, diacerin for 1 to 2 months. The combination of all these result in pain reduction. I don't believe the non-steroidal anti-inflammatory drug except in the first 1 week. I don't prescribe non-steroidal anti-inflammatory drug. Give weightage to the exercises, strengthening of the quadriceps, tell the joint protection techniques, then supplement all these drugs. You can give intraarticular injection also. If there is not contraindicated, there will be pain relief will be achieved. In answering your questions simply for few months, diacerin and hyaluronic acid.
So is there any role for vitamin D? Because I see a lot of patients.
As far as the references I have gone through, nowhere it is mentioned for osteoarthritis knee. But generally, we all will have vitamin D less than 10. So
Yes.
nothing wrong in supplementing. Nothing wrong in supplementing. It is good for the entire body, but per se, osteoarthritis, I do not know whether it will have beneficial effects.
And so about calcium supplement?
Almost the same answer. I don't think it is needed. Because that is why I discussed the articular cartilage histology. The articular cartilage consists of outer perichondrium, deep to the perichondrium, it has a collagen and chondroitin sulfate, which are all lost during the degeneration. So you have to supplement. If you want to supplement, you can supplement collagen as well as chondroitin sulfate. Somebody has asked what is Rosiflex trio. I think it must be chondroitin sulfate, glucosamine sulfate. The other part I don't know. It varies from state to state.
Sir, if I ask you that what are the three most important steps in the management of osteoarthritis? What would be your answer?
Number one, activity modification. That's a joint protection techniques. You have to save the remaining articular cartilage. This is one. Then judicial use of non-steroidal anti-inflammatory drug. Third one, give importance to the exercises, strengthening of the quadriceps and strengthening of the hamstring. You asked three, I told three. Fourth one, the supplementation. Glucosamine sulfate, chondroitin sulfate, hyaluronic acid. Fifth one, steroid.
Do you use platelet-rich plasma or?
I have done only once in the department, but it is practiced in our institution in the orthopedics departments.
Okay.
They say the speeds up the healing process. Usually, actually, it's a degenerative disease. There is no inflammation, but there will be secondary inflammation. The inflammatory mediators will irritate the synovium, and there will be secondary inflammation. That may be healed with the platelet-rich, plasma-rich platelet.
So what are the exercises we can prescribe for strengthening the quadriceps, because movement itself is painful, isn't it?
No, it is not.
Please repeat the question, sir.
No, sir. What are the exercises we can prescribe for strengthening the quadriceps?
Okay.
Because I feel that the movement itself is painful, isn't it? So how can we strengthen the quadriceps without movement, without exercise?
So, see, we start with non-steroidal anti-inflammatory drug and other measures also. When the pain comes down, simultaneously we start strengthening of the quadriceps. The technique, you have to keep the pillow under your knee and ask the patient to contract. It's called isometric contraction of the quadriceps. Similarly, for hamstring, you flex the knee and ask the patient to press the heel. That will contract the hamstring. As well, the stretch is also important because of the spasm. The quadriceps and hamstring will be in tightness. So you have to stretch the quadriceps as well the hamstring.
We can move on to the next topic.
Okay,
And
right.
the importance of osteoarthritis is that everybody will have osteoarthritis now. Maybe, as I told, maybe after 50 years, everybody is supposed to have osteoarthritis. And whenever you see a patient, even with cancer, they will also have knee problem. So it is very important for us to understand the symptoms and how to assess and how to manage osteoarthritis. Yes, sir.
So one more question I want to ask.
Yes, please.
So one more question. Yeah. So what will you choose? Intra-articular steroid versus intra-articular hyaluronic acid versus intra-articular PRP?
You can try all the three. You can try all the three with interval of 2 weeks. For people more than 70 years, I give intra-articular steroid first because there will be severe pain. Okay, for old people, I give steroid. And other people, you can try hyaluronic acid. The only thing is quite expensive, 25,000 rupees, hyaluronic acid. They assured pain relief for 3 years because it lubricates the joint.
Sir, you said it's mostly a nociceptive pain, not a neuropathic pain, right?
It is not neuropathic. And
So
nowhere he told about neuropathic pain.
Will morphine help in very severe pain?
It will. Definitely it will.
Can we use it on long term?
No, when the patient is pain score is 8 or 9, to reduce the pain, you can give morphine, nothing wrong. 10 milligram patches you can give. it is not a neuropathic pain, sir. It's a nociceptive pain. Shall we proceed to the next topic?
Thank you, sir.
Okay, right. Okay, next topic again is spinal cord injury rehabilitation. Next. Next. Okay. A 25 years old mason fell down from a height of 300 feet while working at the construction site and broken his D9 vertebra. He became paraplegic at dorsal level D12. After the initial stabilization in the district headquarters hospital, he was referred for rehabilitation. He is bedbound. His urinary bladder is catheterized. He has a pressure sore in the sacral area, 10 into 15 centimeter size. He is the only breadwinner of the family. How will you rehabilitate him? His wife asks you whether he will be able to walk again normally. Now you are the medical officer. The patient is shifted to your hospital for palliative care. How will you proceed? You can type in the chat box. Tomorrow, if such a case come to your center, what will you? The wife has asked you a question, whether my husband will be able to walk. You have to answer.
If anybody wants to speak, you can unmute and speak also.
Okay, no questions in the chat box, so I will proceed. Manage bed sore. Okay, start rehabilitation. How? First, attend to pressure sore. Okay. Passive exercises. Good. So we have got 3 answers. Address the pressure sore, passive exercises, start rehabilitation. Pressure sore will kill a patient. You cannot take it lightly. Pressure sore will kill a patient. Okay, if no other answer, I will start. Next. So whenever you receive the patient, after eliciting history, we assess the patient. Next. So in the spinal segment, we have 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. So total number of spinal segments are 31. Next. Spinal nerves, again 31 pairs, cervical 8, thoracic 12, lumbar 5, sacral 5, coccygeal. Next. So each spinal segment will have a motor function, sensory function, and a reflex. Next. So motor function, so myotome, sensory function, dermatome, reflex. Next. So myotomes, I quickly go through, you can stop me at any time. The total mass of muscles supplied by a single spinal nerve is called myotome. So C1 spinal nerve innervates the muscles of the suboccipital triangle. C2, C3, C4 muscles of the neck, C5 deltoid, C6 spinal nerve biceps, C7 triceps, C8 long flexors of the fingers, namely flexor digitorum superficialis. Next. And in the dorsal level, D1 spinal nerve intensive muscles of the hand, D2 to D5 intercostal muscles, D6 to D9 upper abdominal muscles, D10 umbilicus, D11, D12 lower abdominal muscles. L1, L2 quadratus lumborum, L3, L4 quadriceps, L4 tibialis anterior, L5 extensor hallucis longus, S1 plantar flexors, namely the gastrocnemius plantaris, S2 knee flexor hamstring, S3, S4, S5 external ulnar sphincter. You have to go through these 10 times, then you will be familiar. Suppose if I test the L1 spinal segment, I have to test the muscle quadratus lumborum. You can feel the muscle just above your iliac crust. Above your iliac crust, you can feel this muscle. This helps in pelvic hiking. You can lift your leg above the ground. it's a pelvic hiking. This is done by quadratus lumborum. So you test this quadratus lumborum. If it is not acting, that means the L1 segment is not acting. Like that, you have to come from C1 to S5. So you test all the spinal segments starting from cervical 1 to S5. Then you will find out where is the spinal cord is damaged through myotomes. Next. Then dermatomes. A strip of skin supplied by a single spinal nerve is known as a dermatome. So C1 spinal nerve, there is no dermatome. C2 area behind vertigo-oropmental line. C3 is a necklace area. C4 infraclavicular fossa. C5 tip of the shoulder. C6 outer aspect of the forearm. C7 middle finger. C8 medial two fingers. Next. D1 inner aspect of the forearm. D2 above the nipple area. D3 axilla. D4 along the nipple. D8 rib margin. D10 umbilicus. D12 pubis. Next. L1 inguinal ligament area. L2 pocket area. L3 lower medial part of the thigh. L4 medial aspect of the leg extending to the medial malleolus. L5 lateral aspect of the leg over the medial two toes. S1 lateral aspect of the sole where we scratch for the plantar reflex. S2 popliteal fossa. S3, S4, S5 concentric area around the anus. Next. So by testing the sensation with the pin or cotton, previous one please, previous slide. So by testing the skin with the help of cotton or pin, you know whether the spinal segment is intact or not. I told you L1 spinal nerve innervates the skin over the inguinal ligament. Inguinal ligament stretches between the anterior superior iliac spine and pubic tubercle. So that area, there is no sensation, numbness. That means L1 spinal segment is not acting. Next. Then each spinal segment is responsible for reflexes. The upper abdomen D7 to D9 for abdominal reflex, lower abdominal reflex D11 to D12. Cremastic reflex mediated by L1 spinal nerve, anal reflex S4, S5, plantar reflex S1. It's wrongly typed as L1, it is S1, plantar reflex. Next. Biceps C6, C5, supinator C6, triceps C7, knee jerk L3, L4, ankle jerk S1, palpogrammalar reflex S2, S3, S4. Next. Don't bother about the previous 6 slides. It's easy. If you can spend half an hour, you can memorize all the myotom, dermatom reflexes. The idea of telling all these things to you is, suppose if you want to know which spinal segment is affected, you must know what is the muscle innervated by the spinal segment, what is the area of the skin supplied by the spinal segment, what is the reflex mediated by the spinal segment. If you test the myotom, dermatom reflex, then you can find out the spinal segment is acting or not acting. Suppose if I want to test L1 spinal segment, the L1 spinal segment myotome is quadratus lumborum, superior to right pelvis. If it is not acting, L1 segment is myotome is not acting. L1 dermatome, inguinal region, anterior superior iliac spine to the pubic tubercle. If that area numbness, then L1 dermatome is not acting. Then the reflex mediated by the L1 spinal segment is the previous slide, please. Previous one, the previous one. Okay, grimmastic reflex. You scratch the medial aspect of the thigh of the male patient, the scrotum will elevate. This is a grimmastic reflex. So for testing the L1 segment, I tested the muscle quadratus lumborum, then I tested the skin in the inguinal area, then I tested the reflex, grimmastic reflex. How to test the C7 spinal segment? C7 spinal segment, myotome, triceps. Dermatome, tip of the middle finger, reflex, triceps reflex. Like that, each spinal segment has a myotom, dermatom reflexes. If you are familiar with this, you can 20 minutes time, you can find out which spinal segment is not acting. In your center, you may receive a patient with a discharge summary. I don't think your center will receive any acute paraplegia. Okay. The patient stabilized, surgically stabilized, will be shifted for palliative care. So the discharge summary will say, in the case history I told you, he has a fracture of the D9 and paraplegic at D12. So history will be clearly given in the discharge summary. But still, you have to evaluate. Then only you know what are the muscles acting, what are the muscles not acting, what are the problems, where you have to focus. That's why you have to do all this, the testing of all the spinal segments. Next. So neurological level. In the case history I projected, the neurological level is D12. It is the most caudal neurological segment of the spinal cord that it retains normal motor sensory function on both sides of the body. Next. This is a case history I projected. So the patient has neurological level, the patient neurological level lesion is D12. The patient is paraplegia at D12 spinal segment. That means D12 spinal segment, motor, myotome, dermatome, reflexes are intact. Below D12, we have L1 segment. The L1 segment myotome, already we discussed quadratus lumborum, that will not act. The dermatome, the inguinal area, numbness, and the reflex, the scrotum may not elevate also. So neurological level means at the spinal segment, which has the retained the motor sensory reflex level is the neurological level. Next. Complete lesion means you have to test the last spinal segment, which is the last spinal segment, S5 spinal segment. The S5 spinal segment motor is external anal sphincter, sensation around the external anal sphincter, reflex anal reflex. So how to test the external anal sphincter? You keep your glove index finger in the anal orifice, ask the patient to grip your finger. The patient is able to grip, that means it is an incomplete lesion. If the patient is not able to grip, the external anal sphincter is very patulous, then there's a complete lesion. Next. Incomplete lesion at the last spinal segment, that is S5, motor sensory may be preserved. Next. So when you receive the patient, you have to assess the patient. You have to assess all the 31 spinal segments through myotome, dermatome, reflexes. Then you have to grade the patient. ACA, American Spinal Cord Injury Association impairment scale. There are 5 grades: A, complete lesion; B, C, D, incomplete lesion; E, normal. A is complete lesion. That means the last spinal segment, S5, there is no motor function, no sensory function. The prognosis is very poor. There will not be any recovery at all. B, C, D are incomplete lesion. That means sensations are intact, but motor power less than 3 in B. C, incomplete lesion, sensation intact, motor power more than 3. Grade T, incomplete lesion, sensation intact, motor power is more than 3. Grade E, patient had a fall, he had an injury, he had a fracture of the vertebra, spinal cord injured, but it retains all the function. That is called American Spinal Cord Injury Association impairment scale. Next. So after assessing the patient, this is our diagnosis, a case of traumatic spinal cord injury because he fell down from the height of 300 feet, 20 days duration. Acute care management happened in the district headquarters hospital. Asia impairment scale C, incomplete lesion, level of lesion, motor D12, sensory D12, reflex D12. That means D12 segment is intact. Complication, I think he came with a catheter, so there's a bladder involvement. He came with a bed sore, sacral fracture. So next. Now we have to rehabilitation the patient. Rehabilitation is a teamwork. Next. So in the rehabilitation, we have medical members, almost all the specialty, physiatrist, orthopedic surgeon, neurologist, neurosurgeon, plastic surgeon, and so on. And the physiatrist is a specialist in physical medicine rehabilitation, is the leader of the rehabilitation team. Next. Next. So the function, the role of the physiatrist is the clinical assessment of the patient. Then he will arrive at functional diagnosis. He will evaluate the disability, sorting out the line of management. If necessary, he will do the rehabilitation surgery and review and follow up and statistic and coordinate with the other members of the team. Next. Then we have very important paramedical team members, physiotherapist, occupational therapist, prosthetic arthritis, rehabilitation nurse, audiology, speech pathologist, and psychologist. Next. We have socio-vocational members like social worker, vocational evaluator, vocational counselor, child development specialist, special educator, placement officer, governmental agencies, employment agencies, industries, bank, non-governmental organization. So the rehabilitation team consists of medical members, non-medical members, and socio-vocational members. Next. I would like to introduce two terms. I think you may be familiar with the multidisciplinary team and interdisciplinary team. I take 1 minute time. You can type if you know the answer. What is the difference between multidisciplinary team and interdisciplinary team? I can wait for 30 seconds. The chat box. I'm sure you have heard about the term multidisciplinary team. The chat box I read, his wife has asked whether my patient will be able to walk. Somebody, Paul Rena, has typed, counsel wife that he may not regain all power, provide wheelchair. I will come to that later. Okay. Now we'll see the multidisciplinary team and interdisciplinary team. Next, please. Next, please. Okay. This is the rehabilitation team members. Okay. Next. In multidisciplinary team model, there will be attending physician, involvement of multiple professionals. There will be vertical communication with the patient, no lateral communication with the team members. There is no group synergism. It's an obstacle to the optimal use of multiple professionals. Next. Interdisciplinary team, the same people, but there will be an attending physician, involvement of multiple professionals. There will be patient care coordinating conferences. There will be lateral communication flow. The team members discuss among themselves, if not daily, once in a week, what each other is doing, how to do better. There will be free exchange of ideas. There will be group synergism and group decision making. Next. Now tell me which is the best rehabilitation model. In both team, multidisciplinary team and interdisciplinary team, the same team members are same, only the approach is different. So among the two, which is the best model? Yes, it's an interdisciplinary because they discuss among themselves. That's good for the patient. Next. The goals of rehabilitation as far as this patient is concerned. Next. Independent ambulation, normal voiding, management of pressure, so vocational rehabilitation. Next. His wife asked you, will my husband be able to walk? So you have to answer scientifically. You cannot say he will not walk. You have to justify whatever statement you give, you have to justify. You can say he will not walk for the following reasons. Or you can say he will walk for the following reasons. Next. There is one index called ambulatory motor index designed by Water and Associates. It's an indicator of ambulatory capacity. Next. In ambulatory motor index, we have to test 5 muscles at the level of the hip 3, at the level of the knee 2, at the level of the hip flexor, abductor, extensor, level of the knee flexor, extensor, the hip flexor, iliopsoas, hip abductor, gluteus medius and minimus, hip extensor, gluteus maximus, knee flexor, hamstring, knee extensor, quadriceps. These 5 muscles you have to test on both sides. So how many muscles? How many muscles? You have to test 5 muscles on each side. Hip 3, knee 3, so total 10. Cyroplif, there are 10 muscles. And generally we follow the MRC grading. Here they have used different grading. Next, please. This is the MRC grading. They have not followed the MRC grading. Next, please. So it's a 4-point scale. No movement at all or no power at all, 0. Poor, 1, fair, 2, good, 3. So what will be the minimum score? What will be the maximum score? The ambulatory motor index. What will be the minimum score? What will be the maximum score? You are testing 0, 15. Any other answer? Sunil sir has responded minimum score 0, maximum score 15. Any other answer?
0, 30.
That's a fantastic answer, Paul. Okay, I told you there are 5 muscles on each side, so totally 10 muscles. Okay, and the scoring 0, 1, 2, 3. So total score will be 30. Next, please. Now the grading. If the score is 24 and above, the patient may not require any orthotic device. If the score is more than 18, he may require 1 knee ankle foot orthosis. If the score is less than 12, he needs orthosis on both sides. So if more than 24, no orthosis required. This happens when the patient has cauda equina lesion. Next slide. So this is the cauda equina. It is below the spinal cord ends at the level of the L1 vertebra. Below that, you have all the spinal nerves. Okay, they form a horse tail. When injury occurs to the cauda equina, it behaves like a peripheral nerve injury, like wrist drop, like your class hand. So a patient with cauda equina lesion will walk definitely. Next. So with this score, you'll be able to tell the walking capacity. What is KFO? I am coming. What is KFO? So with this score, you'll be able to answer the relatives whether the patient will be walk or not. If walk, independent walking, or with the orthosis. Next. So goals are independent ambulation. Next. So which orthosis we have to decide? It will be decided by the muscle power of the patient. Next. So our patient has at the level of the hip, muscle power, MRC grading 1, knee 1, ankle 0. Next. If the hip abductors and extensor are less than 3, the hip is unstable. So the patient requires hip, knee, ankle, foot orthosis. If the hip is stable and the quadriceps power is less than 3, knee is unstable. He requires knee, ankle, foot orthosis. Hip power is more than 3, knee power is more than 3, but at the level of the ankle, dorsiflexor, plantar flexors are less than 3, the patient requires ankle foot orthosis. So in the management of paraplegia, we have 3 types of orthosis. 1, hip, knee, ankle, foot orthosis. We also call long leg brace. It starts from the hip, ends at the toe. Hip, knee, ankle, foot orthosis. If the hip muscle power is adequate, he requires knee, ankle, foot orthosis. The hip and knee are stable, he requires ankle, foot orthosis. Next. So this is the hip, knee, ankle, foot orthosis. I have highlighted the joints: hip joint, knee joint, ankle joint is hidden here under the strap. Next. So orthosis is an external support. Next. So hip, knee, ankle, foot, HKAFO stands for hip, knee, ankle, foot orthosis. KAFO stands for knee, ankle, foot orthosis. AFO stands for ankle, foot orthosis. Next. These are the various components of orthosis. Next. So it has a boot, uprights, and 3 joints, and these are the supports. Next. So here comes the role of the prosthetic orthotic personnel in the rehabilitation team. He will make the hip, knee, ankle, foot orthosis as per the instruction given by the physiatrist. Next. So the patient was prescribed a hip, knee, ankle, foot orthosis. Whenever the hip, knee, ankle, foot orthosis, a long leg brace is given, the patient should be also given crutches, either axillary crutches or elbow crutches. Next. Next. Now, here comes the role of the physiotherapist who will teach the patient the gait training or walking training with the orthosis and crutches. Next. Next. So we have achieved independent ambulation as per it is decided by the muscle power at the level of the hip, knee, and ankle. Next. Our Mason patient has an automatic bladder, human bladder, because he was brought with a bladder catheterized. Next. I'll briefly tell the normal micturition process and what happens to our patient. Paraplegic patient, he developed automatic bladder. How to manage the automatic bladder? So the kidneys are abdominal organ, retroperitoneal structures. They filter the plasma, urine is formed. They are trained through the ureter into the bladder. Bladder is a pelvic structure. We cannot feel the bladder. The normal capacity of the bladder is 400 ml. Then we void urine. For some reason, if you are not able to void urine, and the urine accumulates in the bladder, the capacity may go up to 1 liter. And the urine bladder distended up to 1 liter, then it become an abdominal organ. You can palpate the bladder. Next. So in the bladder, there are 3 openings, opening by the 2 ureters and opening of the urethra. So there are 3 openings. They form a triangle here. It's called trigone. Next. In the trigone, there are stretch receptors. So when the bladder is filled with urine, the stretch receptors are stretched. The stretch impulses are taken from the bladder. Next. Next. Right. Now when the bladder is filled with urine, the trigonal area is stretched. The trigonal area, we have stretch receptor. From the stretch receptors, the impulses are carried by parasympathetic afferent S2, S3, S4 spinal segment. The S2, S3, S4 spinal segment is the spinal micturition center. This is the dorsal root ganglion. This is the S2, S3 spinal micturition center. From the S2, S3, S4 segment, the impulses ascend up through the spinal cord. They reach the pons. In the pons, we have another micturition center called pontine micturition center. From the pontine micturition center, the impulses reach the sensory cortex. When the impulses reach the sensory cortex, we are aware that our bladder is filled with urine. Okay. But we cannot pass urine wherever we want, what time we want. Okay. From the sensory cortex, the impulses reach the frontal lobe paracentral lobule. The paracentral lobule decides if the atmosphere is socially convenient, it will send facilitate impulses. Otherwise, if the atmosphere is not socially convenient, now you are in the classroom, you cannot pass urine. So the paracentral lobule will send inhibitory impulses to the spinal micturition center, S2, S3, S4. When you have a privacy, the class is over, you can move to the toilet. Now the paracentral lobule in the frontal lobe send facilitatory impulses to the spinal micturition center located at, you can chat, you can type. The spinal micturition center located at the spinal micturition centers are located in the, exactly, very good, S2, S3, S4 segments. Now you are alone. The facilitatory impulses from the paracentral lobule has come to the S2, S3, S4 spinal segments. In the sacral segments, we have anterior horn, posterior horn, lateral horn. Lateral horn, we have the autonomic nervous system neurons. The anterior horn, we have motor neurons. From the S2, S3, S4 motor neurons, pudendal nerve comes out. The pudendal nerve always keep the internal urethral sphincter in a contracted stage. Okay. Now, when the order comes from the frontal lobe, then the pudendal nerve relaxes the external urethral sphincter. This is called ignition. Now, the lateral horn of the S2, S3, S4, we have parasympathetic afferent neurons. This will contract the tetrasaur. One side, the external urethral sphincter is relaxed. Now tetrasaur is contracting, there will be micturition. This is a normal micturition. Shall I quickly repeat it again? When the bladder is filled with urine, the stretch receptors in the trigonal area are stretched. The stretch impulses are carried by the parasympathetic afferent to the S2, S3, S4 spinal segment, that is the spinal nutrition center. From there, the impulses ascend up the spinal cord, they go to these pons, there will be a pondine nutrition center. From the pondine nutrition center, the impulses reach the sensory cortex. When the impulses reach the sensory cortex, we are aware our bladder is distended. From the sensory cortex, impulses reach the frontal lobe, paracentral lobule. The paracentral lobule decides whether it's the time to pass urine or not. If it is socially convenient to pass urine, the paracentral lobule sends facilitatory impulses. The facilitatory impulses reach the S2, S3, S4 segments. Two things happen. Number one, the anterior horn motor neuron, they relax the external urethral sphincter to the frontal nerve. Then the parasympathetic S2, S3, S4 neurons contract the tetrasaur. So a relaxation of the external urethral sphincter, that is called ignition, followed by contraction of the tetrasaur. Then there will be a normal micturition. Next, please. So this is the pondine micturition center. So we have two micturition centers. One at the spinal cord, S2, S3, S4. Another one in the brain, pons. Next. So we have the centers involved are cortical micturition center in the frontal lobe, pondine micturition center, spinal micturition center, peripheral nerve, S2, S3, S4. Next. 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 Okay. What happens in paraplegic? A paraplegic will have any one of these three bladder: atonic bladder, automatic bladder, autonomous bladder. He fell from a height of 300 feet. There will be spinal shock. He will have an atonic bladder. Next. Next, please. In spinal shock, there is total neuronal inactivity. Okay. So but still the kidneys are filtering the plasma, urine is formed, the bladder is filled with urine. Unfortunately, from the bladder, impulses cannot reach the spinal micturition center because the impulses are not conducted. So the urine will be accumulating in the bladder. There will be increased size of the bladder. There will be increased volume of the bladder. Because of the increased volume of the bladder, some pressure is developed. The intravesicular pressure, because of the increased intravesicular pressure, some urine will be dripping. So in atonic bladder, there will be retention, extension, and overflow. So until the spinal shock goes off, we will put the catheter, Foley's catheter. Next. Next. Okay. What happens to our patient? Our patient has automatic bladder. This is automatic bladder. Next. Okay. Okay. Can anyone tell me what is the level of lesion in our patient? What is the level of lesion? I projected twice that slide. Excellent. So he had a fracture of the vertebra D12. So in the D9, he had a fracture of the D9 vertebra. The D9 vertebra occupies they hold the D12 spinal segment. Okay, the spinal segment, the segment is intact. Below that, the L1, L2 are not acting. So the level of lesion is D12. Okay. Now what happens to our patient? His bladder is filled with urine. Okay. The impulses are carried by the parasympathetic afferent S2, S3, S4 to the spinal micturition center. Is it possible here? Will this happen? Our patient, a D12 paraplegic person, his kidneys are filtering the plasma, urine is formed, the bladder is filled with urine, the trigonal area stretch sensors are stretched, the stretchy impulses are carried by the parasympathetic afferent to the spinal micturition center. Will this happen? No. Will this happen or not? Our patient presented with atonic bladder during the spinal shock, where there is no neuronal activity. The spinal shock will go in 1 week, 10 days time. Following that, our patient developed automatic bladder. Now you tell me whether this will happen. When his bladder is filled with urine, the stretch receptors are stretched, the stretch impulses are carried to the spinal center by parasympathetic S2, S3, S4. Will this happen? Parul Raina, will this happen? He has come out of the spinal shock. Yes. Now the answer is yes. He has come out of the spinal shock. Okay. So his impulses reach the S2, S3, S4 segments. Now the impulses are down. Where should they go? From the S2, S3, S4, where should they go? Where should the impulses go? You can chat. You can type. Pons. Biju, very good. Now the impulses must reach pons. It should reach pons. Will in our patient will the stretch impulses reach the pons? No, Biju, very good. No, because there is a lesion here. There is a lesion here at the level of the L1 vertebra, lesion here. The impulses cannot cross this because the continuity is not there. So impulses stop here. Okay. What happens? The S2, S3, S4, we have a dorsal root ganglion. In the absence of the higher center, the dorsal root ganglion gives order. You contract. Okay. So the dorsal root ganglion gives orders to the S2, S3, S4 segments. When this happens, the tetracer muscle contracts. What is missing? Spinal reflex develops. What is missing? The stretch reflexes cannot ascend up. They cannot go to the pons because of the disconnection. Then the S2, S3, S4 takes the upper hand. That the dorsal root ganglion takes the upper hand. It gives order. Okay, you contract. Tetracer contracts. What is missing? Pudendal nerve action is missing. Very good, Biju. Pudendal nerve. Because I used the word, one particular word. Can anyone type? I used one particular word. I used the word ignition. This is a word given in the book Ganam by the physiology book. That's called ignition. When we start the engine, we turn the key. That's the ignition. Okay. So first step for maturation is the pudendal nerve must be relaxed. Then only the external urethral sphincter will be relaxed. Then the tetracer must contract. But here the order comes from the dorsal root ganglion, not from the frontal lobe. So the pudendal nerve is not acting. The external urethral sphincter is still in a contracted state. Unfortunately, the tetracer contracts. So what will happen? The external urethral sphincter is in a contracted stage. Tetracer is contracting. What will happen? The answer is simple. Not able to pass urine. This is a retention, but still it is contracting. Definitely he cannot pass urine. Unfortunately, tetracer is contracting. So there will be pain and overflow inconfidence. Biju, so something will happen. Can anyone refine this answer? External urethral sphincter is contracted, but tetracer is contracting. So what will happen? The fluid must go somewhere. The urine in the bladder must go somewhere when the tetracer contract. Where else it will go? Reflex. Where will it go? No, where will it go? Hydronephrosis. That's a fantastic answer. Hydronephrosis. There will be backflow of urine. The urine will go through the ureter to the kidney. That's all hydronephrosis. Very good. Okay. Right. Next, please. Next. Okay. So previous one, please. So this is the human bladder, human type of bladder. Okay, where it's a reflex bladder. It is always contracting because of the order coming from the dorsal root ganglion. Tetrusar is always contracting. It's an automatic bladder, low volume bladder, hyperreflexia. There is incoordination between the sphincter and tetrusar. Normally, the sphincter must relax, then tetrusar must contract. Here, there is no relaxation of the sphincter. There is only contraction of the tetrusar. This is called tetrusar sphincter dyssynergia. That will result in vesicourethral reflux. There may be backflow of urine into the kidney. Because of the contraction, there will be tetrusar hypertrophy. Next. So how are you going to manage the automatic bladder? So we have to control the contraction of the tetrusar by the anticholinergic drug. Propandolene we use hydrochlorine for 15 milligram thrice. Next. Then we have to relax the external urethral sphincter by the alpha adrenergic blocker, terazosin or the baclofen. So we have relaxed the external urethral sphincter. Then we have the tetrusar action is also minimized. Next. Now we follow 3 voiding techniques. We ask the patient to compress or the attenders give suprapubic tapping. Now the external urethral sphincter is relaxed by your drugs. There will be voiding. Or we ask the patient to strain Valsalva maneuver. There's a forced expression against the glottis. Then we follow a schedule called drinking, voiding, catheterization schedule. What is that? Next. In drinking, voiding, catheterization schedule, it's also called timed voiding program. We allow the patient to take water that is required for the normal renal function. 400 ml of water with 3 major meals, 1200 ml. Then 200 ml of water at 10 o'clock, 4 o'clock, 10 p.m. So totally, the patient will be taking only 1800 ml. Next, this is the drinking schedule. Voiding schedule, voiding on awakening, voiding 1.5 hours after main fluid, void every 2 to 3 hours, void before going to bed, void during night. Because we have relaxed the external urethral sphincter by medicine, the voiding can be done by compression or straining. Next. Then we also teach the patient clean intermittent catheterization, which the patient has to do for once in 6 hours. What is clean intermittent catheterization? Next. So men with lesion T1, a paraplegic usually will have a normal upper limb function, so they can do self catheterization with the rubber catheter. So we have to teach the patient, clean the hands with soap and water, clean the catheter also, then safely he has to infuse the catheter into the urethra without damaging the urethra. Next. So the complications of clean intermittent catheterization, we may be introducing bacteria into the urethra, urethral trauma, bladder stone. Right. Next. So we have achieved independent ambulation with the help of the orthosis. Then we have achieved normal voiding by prescription drugs and following the drinking, voiding, catheterization schedule. Usually it will take 6 weeks time to achieve these goals. Next. Our patient presented with a sacral pressure sore of size 10 into 15 centimeter. Next. So whenever we get a patient with the pressure sore, we have to stage the pressure sore. Whenever a patient develops pressure ulcer, it is a disgrace to the rehabilitation team because the rehabilitation nurse and the rehabilitation physiotherapist, they have not focused their attention. They were careless. Because of the carelessness, the patient developed pressure sore. Staging of the pressure ulcer, according to the National Pressure Ulcer Advisory Panel, there are 4 stages. Stage 1, non-plungeable erythema. Stage 2, partial thickness loss of skin in the epidermis and dermis. Stage 3, full thickness loss of the skin. Stage 4, loss of the subcutaneous tissue. Next. Here it is picturized. It's a non-plungeable erythema. Epidermis and part of dermis lost. Epidermis, dermis lost. This is subcutaneous part is also lost. Next. So this is an assessment. This assessment is a acronym. A stands for what is the location of the ulcer. Then S stands for what is the size of the ulcer. S stands for whether it is any infection, what is the X-ray surrounding the ulcer, any sinus tract, any maceration, how the edges, any smell, and what's tenderness. So assessment is acronym. Next. Now we have to treat the pressure ulcers. So first we have to clean the wound. We use 4 types of solution: povidone iodine, acetic acid, sodium hypochlorite, and normal saline. Next. Then when we clean the wound, we observe there are some dead tissue in the pressure ulcer. So dead tissues must be removed so that the wound will heal faster. It's called debridement. Next. So debridement is done by several ways. We have proteolytic enzyme that will remove the collagen. Next. Then mechanical debridement by forcibly irrigating with water or wet to dry pressing, or with the needles, or with a knife we can remove the dead tissue. So called shock debridement. So we clean the wound, then we remove the dead tissue. Next. Then we cover the wound. We have to put a dressing. When you put the dressing, it must serve 2 purposes. Number one, it should not allow the infection to enter. Also, the dressing must absorb the exudates. So we have transparent adhesive dressings. Next. We have hydrocolloid wafer dressings. Next. We have gel dressings. Next. We have calcium alginate dressing. So in the center, whatever the dressing available, you can do. You have to see that the dressing must be the absorbent, remove the exudates. So we clean the wound, we did the debridement. Now we have put the dressing. Next. Surgical consideration. If in spite of all these things, the wound is not healing faster, then you have to think about the surgical consideration. Next. So we have direct closure. If the wound is very small, the ulcer is very small, then you can do direct closure. Next. Next. Then you can do skin grafting, skin taken from one area and harvested over the ulcer area, skin graft. Then next. Then skin flap. The difference between skin graft and skin flap is in skin flap, there will be the blood supply of the grafted skin will be intact. So it will take up quickly. Next. Musculocutaneous flap. The sacral pleasure zone will be very deep. So the skin alone may not be adequate. The patient needs the skin as well as the underlying muscles. It's called musculocutaneous flap. Next. Free flaps. In free flaps, the skin is taken from one area, harvested over the ulcer area. Then in the ulcer area, the blood vessel in the skin is connected to the blood vessel in the ulcer area. It's a microscopic procedure called free flap. Next. Then we have to provide special beds for the patients called support services and special beds. Next. Next. So we have 2 types of beds. One is pressure reducing, another one is pressure relieving. What is this pressure? I'll come to this next slide. Next. So what you see is the mattress overlay, the white color, the mattress overlay that will reduce the pressure. Next. We have water bed and gel bed. Again, it is a pressure reducing device. Next. We have specialty beds called low air loss bed and air fluid bed. Next. Next. This is a low air loss bed. In the bed, there are small buckets. Each bucket will be inflated and deflated by this water. Next. Here, the bed contains silicone seals, and hot air will be passed through this bed that will warm, that will simulate a fluid environment. That's a pressure relieving pressure. Next. So quickly, the causes for pressure are extrinsic causes, intrinsic causes. Extrinsic, prolonged pressure, interface pressure, shear, friction, immobility. Next. Next. Usually, the ulcer, the pressure ulcer happens over the bony point. And there's a prolonged unrelieved pressure. When the patient is lying down for hours together with moving, there will be the compression of the arteries in the area between the cot and the bony point. Then there will be tissue ischemia, cell death, necrosis, and pressure ulcer. Next. Next. I want to spend 1 or 2 minutes here. It's the interface pressure. What is interface pressure? Interface pressure is the pressure between the surface of your body and the surface on which you are sitting. Now you are all sitting. You are all sitting with our ischial tuberosity. So there will be a compression of the muscles and the blood vessels between the ischial tuberosity and the chair. The interfacial pressure must be less than 32 millimeter of mercury. We have large size aorta, large size arteries, small size arteries, arterioles, capillaries, venules, small size veins, large size veins. Then we have vena cava. In the arterioles, the pressure is 32 millimeter of mercury. When this exceeds, the arterioles will be compressed. When the arterioles are compressed, distal to the compression, there is no blood supply, ischemia, cell death, necrosis. Next. Right, this is a perpendicular force, is the interfacial pressure. Next. Next, shearing force. You might have seen in the ward, the softness may be in the morning when they make the bed, they may pull the bed spread from the patient. So that's the called shearing. Next. And friction between two forces. Next. Immobility. So when the patient is in the immobile for a long time, he may develop pressure ulcer. During sleep, subconsciously, we change posture for every 15 minutes because of the ischemic changes we develop because of the compression of the blood vessels in the arteries. So the patient, spinal cord injury patient, cannot mobile. So he develops ulcer over a period of time. Next. The intrinsic causes are when the patient has hyperproteinemia, wound healing will be delayed. When the patient has anemia, blood supply will be reduced. Hypotension, again the blood supply will be less. Hypoxemia, infection, fever. These are the causes for the physiological causes or intrinsic causes for pressure. So next. So here comes the role of the general surgeon, plastic surgeon, who did the skin graft or skin flap. Next. So we have made our patient to walk. We have taught him the drinking, voiding catheterization schedule. He is able to do the self-catheterization. We have addressed the pressure sore also. Then occasional rehabilitation. His wife asked whether he will be able to walk again. He is a mason by profession. Will he be able to go back to his job? Will he be able to go back to his job? Though he is ambulant with a hip knee ankle foot orthosis, will he be able to go back to his mason job? No, not possible. Yes, not possible. Okay, but still his higher functions are normal. His upper limbs are normal. His upper part of the body, thorax and part of the abdomen are normal. With this, he can manage some other job, alternative job. Next, please. Vocational rehabilitation. Next. So, when we discharge the patient, we provide a disability certificate. Next. For a paraplegic, this is the disability. Paraparesis, 75%. Paraplegia, 100%. Tetraparesis, 75%. Tetraplegia, 100%. Next. So this is a disability certificate we give. Next. Now the patient has to take the disability certificate to his native place where he's to the collector office where he is staying. In each collector office, there will be district rehabilitation officer. The district rehabilitation officer will produce a disabled person an identity card. When the person gets an identity card, he is entitled to enjoy all the benefits given by the government, like next, job opportunity. In corporate companies, my institution is a private institution, we have to provide 4% of our jobs. We are 4,000 people are working here. 4% of our job must be given to a disabled person. We have 30 leaves. All the leaves are operated by disabled persons. So when a person has a disability certificate and the ID card given by the district rehabilitation officer, he is entitled for job opportunity, entitled for quota in the educational institution, free calipers, free crutches, wheelchair, bicycle, free bus pass, free plane pass, self-employment scheme, and bank loan. Next. So he can have a petty shop like this. Will he be able to move out of the house? Will he be able to move out of the house? No, before that, I would answer one question somebody has asked. I have projected the disability certificate of a stroke patient. Okay. Very rarely we get paraplegic patient in our hospital. That's why I don't have a certificate of paraplegic person, disability certificate. The certificate I project is a disability certificate of a stroke patient. Okay. Now the question is whether he will be able to go out of the house. Yes, he can. At the time of discharge, we provide the patient with brace, a long leg brace or hip knee ankle foot orthosis, a pair of axillary crutches or elbow crutches. We provide a disability certificate. We provide a tricycle. We provide a wheelchair. We teach him self-intermittent catheterization. These are the 6 items we provide. Okay. We provide wheelchair for indoor ambulation. Inside the home, you can move with a wheelchair. Outside for community ambulation, we provide tricycle. Will a paraplegic person drive a tricycle? Will a paraplegic person drive a tricycle? Yes. The answer is yes, because his upper limbs are normal. His higher functions are normal. His neck is normal. His trunk is normal. Part of the abdomen is normal. He will be able to sit. If somebody helps him and take him to the tricycle, if he is able to sit, he will drive the tricycle. So from the inside the home, he will move with a wheelchair. Outside the home for community ambulation, he will use the tricycle and he can come to his petty shop. Next. So here comes the role of the medical social worker to get all the benefits given by the government to the patient. Next. So this is our patient. He is bedbound. Now we have make him to mobilize with the help of the hip knee ankle foot orthosis. His bladder was catheterized. We taught him the drinking, voiding catheterization schedule. We also teach him how to do clean intermittent catheterization. So he has a pressure sore. It was healed by the surgical team. And we have the vocational rehabilitation also done by the medical social worker. He has a petty shop. So we have a holistic rehabilitation done. Next. Right. We can discuss for 5 minutes this topic. Yeah, we've taken a long time. (7:15) we start. Right. You can spend 5 minutes for this. There are, I am reading the chat box. There are paraplegic patients selling lottery tickets. They are outside for many hours. Any special seating to provide to prevent pressure ulcer in this heat condition? What appropriate quantity of, what amount of quantity of drinking water? Okay. Any other questions? I hope the bladder part I explained in detail. So next time when you get a patient with a paraplegic person with the catheter, you must know what type of bladder, atonic bladder or automatic bladder. Okay. The paraplegic person is selling lottery, sitting on a wheelchair. Okay. We have to teach them, we have to relieve their weight because his upper limbs are normal. With his upper limbs and the hand rest, they can lift their hip. Because his upper limbs are normal, he can lift the whole body by pressing on the hand rest. Sexual rehabilitation, very, this person is a 27-year-old man. So sexual rehabilitation, yes, we have to discuss with the patient. It's a wide area, and some other occasion we will discuss. Focus, our immediate focus is mobilize the patient. Because when the patient is lying down, he will develop pressure sore, he will develop hypostatic pneumonia, he will develop deep vein thrombosis. All the three will kill the patient. Pressure sore, pneumonia, deep vein thrombosis. The three will kill a patient. So our aim is first is mobilize the patient. Easily it will be achieved in 6 weeks time if the team is good. So tomorrow when you get a case like this, can you confidently approach him? I need an answer in the chat box. Tomorrow you get a patient like this in your center. Can you approach the patient without fear? I told you it's a teamwork. You alone cannot manage a spinal cord injury patient. You need a good team, a team of doctors, a team of nurse, physiotherapy, occupational therapy, prosthetic orthotic technician. Thank you, Biju. Thanks for the confidence. Is it multidisciplinary team or some other team? Biju, it is interdisciplinary team. We are looking for an interdisciplinary team where the team members will interact with themselves, interact among themselves. That is always better. Okay, so we need an interdisciplinary team. I'm sure in the tips, Trivandrum Institute of Palliative Sciences, every Saturday we used to have a class with Sunil sir. Right. Any other questions regarding spinal cord injury? No question, we'll go to the next topic. One question is how to manage the, what about managing frequent urinary tract infection, especially in home care settings? Okay. Number one, the clean intermittent catheterization, we teach the patient. Okay. However clean they do, they wash their hands with soap, they wash the catheter as well. In spite of this, they are capable of introducing the infection into the urethra, into the bladder through the urethra. Okay. So again and again, we have to teach them the technique, sterile technique. That's one. Then any stagnant water, the infection will be there. So they have to periodically empty the bladder. That's why every 6 hours, they have to do the self-intermittent catheterization. Yes, with the injury, several occasions we come across patients with injury to the urethra by the clean intermittent catheterization. So we do supra-PP catheterization so that during the time the urethra will be healed. Instead of urine draining through the urethra, there will be supra-PP catheterization. It is a simple procedure. Any other question in this spinal cord injury? If no other question, we'll move to the third topic. Shall we?
Yes, yes, please.
Yes. Okay. Stroke rehabilitation. Amrita Thambi, thank you. Next. Next. I'm going to discuss the topic in these headings. Next. A 55-year-old Mr. Palisamy developed right side hemiplegia 2 weeks back. After acute care management, he is now referred for stroke rehabilitation to our center. He is a diabetic for the past 15 years. His blood sugar values are fasting 160, postprandial 230, HbA1c 8.6. He is a hypertensive. Current BP is 180/98. He has high cholesterol in his blood. He has weakness of right upper limb, lower limbs. He has spasticity in the right upper limb, lower limb. He has a right shoulder pain. He is aphakic. How will you rehabilitate him? I want at least 2-3 answers. 55-year-old Palnisamy become right side hemiplegic. Weakness of the right upper limb, spasm, right shoulder pain, aphasia. How will you rehabilitate him? I want 2-3 answers. Control of blood pressure, blood sugar, cholesterol. Fantastic. These 3 are the risk factors in this patient. Our patient Palnisamy developed stroke because of these risk factors. So the risk factor must be addressed so that he will not have second stroke. Very good. This is your role. Control of blood pressure, control of blood sugar, cholesterol is the role of the palliative care physician. Any other answer? This answer is fantastic, Biju. If no other answer, I will proceed. Next. Yes, physiotherapy. Right, good. Next slide, please. Next. Next. So whenever we receive a patient, we will elicit the history, and the next step is assessment. Never jump to the treatment part. So we have to assess. Only when you assess, you know what are the problems he has, then you can list out the problems. So assessment of the stroke patient. Next. So you have to assess a stroke patient like a long medical case. When you did MBBS, they give a long case, isn't it? A case with mitral valve stenosis, or a case with a stroke, a case with a spinal cord injury, a case with COPD, like that. You have to assess like a long case. You have to examine the higher functions like conscious, orientation, memory, sleep. You have to test all the 12 pairs of cranial nerves. You have to examine the motor system, muscle power, sensory system, reflexes, bladder and bowel. Next. So you have to assess the muscle power with the MRC grading 0 to 5. Next. So after examination, this is the finding. Our patient has right upper limb muscle power, shoulder level 3, elbow level 2, wrist level 1, hip level 3, knee level 2, ankle level 1. There will be sensory loss on the right side of the body. The tendon reflexes are exaggerated. This is the finding after the examination. Right. Next. So this person has muscle power weakness in the right upper limb, shoulder, elbow, wrist, and right lower limb, hip, knee, ankle. Right. Next. Next. So in the history, it is given he has a spasticity of the right upper limb and lower limb. Next. Spasticity is assessed by one scale called next. Modified Ashworth scale, and there are 5 gradings: 0, 1, 1 plus 2, 3, 4, 0, no increase in muscle tone, 1, slight increase in muscle tone, 1 plus slight increase in muscle tone, manifested by a catch, 2, more marked increase in muscle tone, previous one, 3, considerable increase in muscle tone, 4, affected partition flexion or extension. Next. So with the use of the modified Ashworth scale, spasticity is assessed, and our patient has at the level of the shoulder spasticity in the pectoralis major, spasticity in the biceps, spasticity in the flexor carpi radialis. He has spasticity in the gluteus maximus, he has spasticity in the quadriceps, spasticity in the tibialis anterior. If you analyze, you can see in the upper limb flexors are spastic, lower limb extensors are spastic. Next. 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 So after assessing the nervous system, we use certain scales in the stroke rehabilitation. They are number 1, next. Scandinavian stroke scale. This stroke scale will reflect the neurological status. What is the current neurological status of the patient? There are 9 items: level of consciousness, eye movements, power in the arm, hand, leg, orientation, aphasia, facial paralysis, gait. Next. So 9 items. So patient is fully conscious, 6 points. Somnolent, always sleeping, 4 points. Reacts to verbal command, 2 points. Like this. Next. 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 So there are 9 items. Next. So the total score will be 58. So if the patient score is, he has scored 45 to 50, that means only mild neurological damage. 30 to 44, moderate neurological damage. 15 to 29, severe neurological damage. 0 to 14, very severe. So by using the Scandinavian stroke scale, you know the current neurological status of the patient. The first scale we use. Next. Next. This is a score of our patient. Next. 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 So our patient score, previous one, our patient score is 30 to 40, moderate involvement of the neurological system. Next. The second scale is functional independent measure scale score. The previous scale measured the neurological status. This scale measured the functional activity. What are the functions possible by the patient? It's called functional independent measure. Next slide. There are 18 items. The ratings are 0 to 7. Next. So the total score will be minimum 0, maximum 26. Our patient score was 66. Functional independent measure score. Next. Third score is reverberant mobility scale. This will tell you what is the mobility capacity of the patient, whether the patient will be able to move in the bed, whether the patient will be moved from the bed to the wheelchair, whether the patient will be able to come out of the bed on his own, whether he will be able to walk on his own. This is the reverberant mobility index. There are 10 items. Next. 10 items, each item 10 marks. The total score will be 100 marks. Next, our patient score is some 40 something. His mobility is impaired. Next. Then we use another scale, Orthal index. This will tell about the activities of daily living. Activities of daily living are, bathing, brushing the teeth, or combing, dressing. These are some of the activities of daily living. How he is able to do his ADL is done through this Orthal index. The score will be, there are 10 items. Total score will be 100. The patient score is 0 to 20. He is totally dependent. 21 to 60, severe dependent. 61 to 90, moderate dependent. 91 to 100, slight dependent. Next. This is the Orthal index. Next. 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 Okay. Stroke recovery, there's another scale. Next. Brainstorm stages of stroke recovery. These are all observation by these great people. Brainstorm is a person who is a neurologist. He was in the field for almost 40 years. In his observations, he has written, a patient following the stroke recover in this order. Stage 1, on the day he is in the ICU, there will be flaccid paralysis. After a few days, there will be movement in the synergy pattern. Synergy means mass contraction of multiple muscle groups. We ask the patient to move the wrist, but the patient will move the shoulder, elbow together. This is called synergy. Synergy means mass contraction of multiple muscle groups. So this will happen following the flaccid paralysis. During the recovery, there will be synergy, appearance of synergy, and there will be spasticity. Stage 3, voluntary synergy movements. Stage 4, voluntary movements outside the synergy pattern. Stage 5, developing the control of the individual muscle. Stage 6, return to normal. So a person following the stroke will follow through all the 6 stages and reach normal. Next. Next slide. Next slide. Next slide. So our patient, previous one, our patient is in stage 3, voluntary synergy movements, producing movements across joint. There is increased spasticity. Next slide. So after the neurological examination, we used 5 scales: Scandinavian stroke scale score, functional independent measure score, reverberant mobility index, Orthal index, and brainstorm stroke recovery. This will give you a clear picture about the status of the patient. From here, you can list out the problems. You can plan your rehabilitation. Next. Next. Clinical stroke syndrome. Next. I would like to spend 5 minutes on this blood supply to the brain. Follow me closely. So we have here arch of aorta. In the arch of aorta right side, we have brachiocephalic artery. The brachiocephalic artery divides into subclavian artery and common carotid artery. Common carotid artery divides into external carotid and internal carotid artery. On the left side, there is separate subclavian artery and separate common carotid artery, which divides into external carotid artery, internal carotid artery. The internal carotid artery reaches the brain. Next slide. The internal carotid artery, middle cerebral artery, anterior cerebral artery arises. Then we have vertebral artery. Go to the previous slide. Previous slide. From the subclavian artery, vertebral artery arises. It passes through the foramen transversorum in the transverse process and reaches the brainstem. The vertebral arteries unite to form the basilar artery. Basilar artery divides into posterior cerebral artery. So we have two sets of arteries supply the brain. One, the internal carotid artery through the middle cerebral artery, anterior cerebral artery. We got another artery system called posterior cerebral artery, which is a branch from the vertebral system. So we have anterior circulation and posterior circulation. Anterior circulation is by the internal carotid artery through the middle cerebral artery and posterior cerebral artery. Posterior circulation is through the vertebral artery and through the posterior cerebral artery. Then there are communicating arteries between the anterior cerebral, middle cerebral, posterior cerebral that completes the circle of Willis. Next. 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 The middle cerebral artery supplies the lateral surface of the brain. This is the lateral surface of the brain. This is supplied by the middle cerebral artery. Next, please. In the lateral surface of the brain, this is the frontal lobe, this is the parietal lobe, this is the temporal lobe, this is the occipital lobe. And here the blue line highlights the central sulcus. In front of the central sulcus, we have the motor cortex, premotor cortex. Behind the central sulcus, we have the sensory cortex. Okay, all this area are supplied by the middle cerebral artery. Next slide. Next slide. So this is the lateral surface of the brain, the motor area, and this is the medial surface of the brain in between the two cerebral hemispheres. Here, our human body is represented like this. This is called human homunculus. So in the lateral surface of the brain, in the motor area, the human body is represented like this. More space is given for the hand, space, and tongue. Okay. So the middle cerebral artery supplies this area, motor area, where it is represented in the hand, space, and the tongue. Next. So when the middle cerebral artery blood supply is jeopardized, previous slide. When the middle cerebral artery is blocked, what will happen? I told you the middle cerebral artery supplies the lateral surface of the brain. The lateral surface, we have the motor area and sensory area. In the motor area, human body is represented like this. And the blood supply, the middle cerebral artery is blocked. What will happen? All these parts represented here will lose their function. There will be facial weakness, there will be hand function loss, there will be facial palsy, and the patient may not be able to talk, the patient may not be able to swallow. Okay, this is called human homunculus. So when the middle cerebral artery is compromised, the patient will have all these problems. Next slide. The patient will have contralateral because the pyramidal tract one point cross to the opposite side. So the patient will have contralateral hemiparesis, contralateral hemisensitive loss, hemianopia, aphasia, and right. Next, please. Then we have anterior cerebral artery, which is a branch of, anybody can type, anterior cerebral artery is a branch of, I told it twice. Anterior cerebral artery is a branch of internal carotid. Yes, very good. Biju, very good. Internal carotid artery. Okay. The internal carotid, the anterior cerebral artery supplies the medial surface of the brain. This is the part between the two hemispheres. Next slide. Now this is the medial surface. This is the lateral surface. This is the medial surface. This part is supplied by the anterior cerebral artery. Which part is represented here? Our knee, leg and foot is represented here. So when the blood supply to the anterior cerebral artery is compromised, what will be the clinical feature? The anterior cerebral artery supplies the medial surface of the brain. The medial surface of the brain, our body is represented like this, the knee, leg, and foot. So when the anterior cerebral artery supply is compromised, patient will have the weakness of the leg and foot. So I told you, when the patient has middle cerebral artery stroke, he will have an involvement of the upper limb. When the patient has anterior cerebral artery involvement, there will be involvement of the lower limb. Right, next. Thank you, Biju. Next. Next. Then we have the posterior cerebral artery. I told you these are the vertebral arteries. They arise from anybody? The vertebral artery arise from? I told you they arise from the subclavian artery. They pass through the foramen in the transverse process. Then the two vertebral arteries unite to form the basilar artery. Basilar artery divides into posterior cerebral artery. The posterior cerebral artery supplies the occipital lobe. Next. And thalamus. The posterior cerebral artery supplies the thalamus and occipital lobe. Next. So in the occipital lobe, we have the visual centers. So the patient with posterior cerebral lesion will have hemianopia and thalamic pains. Pain all over the body. Whenever a stroke patient complains of pain all over the body, you think about posterior cerebral artery. Next. 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 Okay, so far I told about three blood vessels: middle cerebral artery, anterior cerebral artery, and vertebral artery, and posterior cerebral artery. Middle cerebral artery supplies the lateral surface of the brain. The patient will have more upper limb involvement. Anterior cerebral artery supplies the medial surface of the brain, where our legs are represented. The patient will have lower limb involvement. Then the posterior cerebral artery, the occipital cortex is involved. The patient will have visual problems, as well memory loss, as well thalamic pain. Next. Next. So we have the next previous one. We have the vertebral artery united to form the basilar artery. Basilar artery gives rise to posterior cerebral artery. So this is the area where we have the hindbrain. The hindbrain consists of midbrain, pons, medulla oblongata. These are all supplied by the vertebral artery and basilar artery. When blood supply in this area is compromised, the patient will have next. Develop brain stump syndromes called Weber syndrome, Benedict syndrome, locked-in syndrome, Miller-Kupler syndrome, Wallenberg syndrome. Next. Next. So with reference to the blood supply, I told about a patient, the blood is supplied by anterior circulation, posterior circulation. Anterior circulation, middle cerebral artery and anterior cerebral artery. Posterior circulation by the posterior cerebral artery. Middle cerebral artery stroke, the patient will have upper limb involvement. Anterior cerebral artery, the patient will have predominantly lower limb involvement. Patient with posterior cerebral artery stroke will have visual problems and memory loss and thalamic pain. Next. What is the pathology of stroke? The blood supply to the part of the brain may be lost by two means. Number one, ischemia or hemorrhage. Next. The ischemia occurs because of the thrombus inside the blood vessel or embolus in the blood vessel. Next. The thrombus, it's an atherosclerotic cerebrovascular disease at major vascular branching area, either at the common carotid artery or vertebrobasilar artery because of systemic hypertension. Injury occurs to the tunica medema, then thrombus formation occurs. When the thrombus blocks the cerebral blood vessels, the blood tissue may not receive the brain tissue may not receive the blood, the patient will develop stroke. Next. 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 Then embolic stroke. Here, always the source of embolism is from the heart, atrial fibrillation, sometimes from the rheumatic valvular disease or coronary artery disease or idiopathy. Next. So far we have discussed the stroke due to thrombus, embolus. Here, there is a hemorrhage in the blood vessels. So either bleeding may be inside the blood, inside the brain, intracerebral hemorrhage or subarachnoid hemorrhage. Next. Next. Next, please. Next, please.
Dr. Ramamoorthy,
Am I audible?
I
Am I
think
audible?
now you are audible.
I think he has discounted.
Sorry, sir.
Sir, please unmute.
Okay, am I audible now?
Yes.
Right. The hemorrhage is the hemorrhage may be because of aneurysms. Next, please. Next, please. So, in the pathophysiology, we have thrombotic stroke, where there is a thrombus in the cerebral vessels, or embolic stroke. Embolus is a small clot from the heart or elsewhere. Then we have a hemorrhagic stroke. This you can easily clinically identify from the history. If the relatives give the history, he was all right. He was eating with us. Suddenly he lost his power in the right side of the body. That means embolic stroke. Embolic, the small embolic has entered into his brain. Okay. Then there's an abrupt onset by, as told by Biju. Thrombotic stroke, it occurs over a period of 6 hours, 8 hours. The patient will numbness, the patient will weakness, the patient will giddiness. Suddenly, then he will develop stroke. That's a onset of thrombotic stroke. So if you elicit the history, you will understand. Sudden onset, you presume it's an embolic stroke. Gradual onset over a period of 6 to 8 hours, presume it's a thrombotic stroke. Next. Our patient has thrombotic stroke. Next. Next. So what are the problems he has? He is a diabetic, hypertensive, high cholesterol. All the three are not under control. Weakness of the upper limb, spasticity of the upper limb, right shoulder pain, epilepsy. Next. So now comes the stroke rehabilitation. Again, it is a teamwork. A single person, a medical person cannot do it. We need a team from all healthcare workers. Next. So it's a rehabilitation team members we see in this spinal cord injury rehabilitation. Next. So we have two options: multidisciplinary team, interdisciplinary team. We have discussed the interdisciplinary team is the best model because where there are group meetings, there will be synergism, there will be exchange of ideas. So this is the best model. Next. 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 Okay. Now, risk factor modification. What are the risk factors for stroke in this patient? Our patient developed stroke because of uncontrolled diabetes, uncontrolled hypertension, uncontrolled cholesterol. Okay, so this risk factor must be addressed. Next. The risk factors for strokes are classified as risk factors modifiable by lifestyle changes, like quitting the cigarette smoking, addressing the elevated serum cholesterol, and addressing the obesity. Next. Risk factor modifiable by medical means, diabetes, hypertension, TAA, carotid arteriostenosis, high blood viscosity. Next. Non-modifiable risk factors, age, sex, race, previous stroke. Next. So the risk factor modification is the role of the palliative care physician. This is your primary role. Next. Next. Therapeutic intervention. Next. Now, when we assess the patient, we assess his muscle power at the upper limb, shoulder 3, elbow 2, wrist 1, hip 3, knee 2, ankle 1. These muscles are weak. These muscles must be strengthened. Next. Physiotherapy management. Next. So we have therapeutic exercise program. First, we have to position the patient in correct position. Otherwise, that will worsen the affected limb. Then we have several types of exercises: passive range of movement exercises, active assisted range of movement exercises, active range of motion exercises, progressive resistance exercises, endurance training. Passive range of movement exercises means each joint has a range of movement. Say, for example, knee. I can flex a knee from 0 to 150 degrees, beyond which the thigh muscles will not allow. I can flex my elbow from 0 to 160 degrees. Like that, each joint has range of motion. Our patient has stroke, so he cannot move the joints. So it is done passively by a therapist. It's called passive range of movement. So in the initial stage, we have to do passive range of movement exercises 5 times or 10 times. This will prevent the muscle wasting. This will prevent the muscle contracture. Then over the period of time, there will be recovery of muscle function. Then we will ask the patient to move the muscles on his own. We will assist him and complete the range of movement. Over the period of time, on his own, he will actively improve he can actively move the muscles. Once he is actively move the muscles, we can strengthen the muscles by doing the resistive exercises. Resistive exercises means exercises done with load, like dumbbells. Then we give endurance training. That means exercising for a longer period. This is the exercise program. Next. So positioning here, he has right hemiplegia. His right upper limb is supported like this. Here he is lying on the non-affected side. Here he is lying on the affected side, but protective way. Here he is lying supine. His affected side is protected. So the position is very important. This should not produce any reflexes. Next. 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 So passive range of movement already we discussed is done by a therapist, the full range of any joint. Next. TOPS theory. Next one. Following the stroke, the patient tries to move his affected limb, but he cannot move because it's paralyzed. So over the period of time, the cerebral cortex realizes the cortex need not send orders to the limb to move because the patient is not able to move. So the brain learned not to use the extremity. This is called TAPS theory. He is a French scientist. He suggested the learned non-use mechanism of the brain. So we have to break the learned non-use mechanism. So we have to inform the cerebral cortex, no, this is your job. You have to keep on ordering the extremities. So we do the passive range of movement exercises. By doing the exercises, the cerebral cortex realizes that part of the function is, that part of the limb is moving. So it gets continuous the information from the extremities. Next. Then after the passive range of movement exercises, when the patient has recovered some muscle power, the therapist will help him to do the active assisted range of movement exercises. Next. Then over the period of time, he is on his own doing the active range of movement exercises. Next. When he is able to do on his own, then he have to strengthen the muscles by giving the load like dumbbells. Next. Next. Then endurance for the ability to do the activity for a long period. Next. So these are the various exercises. These exercises are given by the physiotherapist. Here comes the role of the physiotherapist to teach the patient exercises and give gait training. Next. Advanced rehabilitation technique. Next. There are 5 advanced rehabilitation techniques. Just be familiar with the name. PNF technique, proprioceptive neuromuscular facilitation. Here, the patient is asked to move the extremity in a diagonal pattern. One. Next. Brainstorm movement theory. Here, we make use of the synergy pattern. Can anyone type what is synergy? I told twice. What is synergy? What is synergy? We ask the patient to move the wrist, but the patient will move the shoulder, elbow, wrist together. This is called synergy. Synergy means mass contraction of multiple muscle groups. We make use of the advantage of the synergy to get a function. This is called Brainstorm movement theory. Next. Roots approach. This is a cutaneous sensory stimulation like stroking, tapping, brushing, vibrating, icing to get the movement. Next. Bobath neurodevelopmental technique. There's an inhibition of the abnormal tone to get back the movement. Next. Motor relearning program. Here we ask the patient to do some activities. Sit to stand for 50 times. Make a circle with the shoulder for 50 times like that. This is the motor relearning programs. Next. So these are the advanced stroke rehabilitation technique, PNF technique, Brainstorm technique, roots approach, Bobath technique, motor relearning program. If you have a physiotherapist in your rehabilitation team who has done specialization in neuro rehabilitation, MPT, he will be aware of all these things. He will be an asset to your rehabilitation team. He will be handled. He will be able to do all these things. Next. Okay. Why neurological recovery occurs? The patient was brought to the ICU. There was no movement in the right upper limb, lower limb. Over the period of time, he is able to stand, he is able to walk. How does it happen? It happens by two mechanisms. Number one, resolution of the local harmful factors. The patient is thrombolized. So there will be resolution of the cerebral edema. There will be resorption of the local toxins, improved local circulation and recovery of partially damaged ischemic neurons. These are the one reason for neurological recovery. Second one. Next slide. Neuroplasticity. Neuroplasticity is assumption of the function by undamaged redundant nearby neuronal pathways. Here I have highlighted this area is damaged. This is the motor cortex. Motor cortex. Here blood supply is lost. The patient have a stroke. With the repeated exercises, the adjacent area close to the damaged part will carry over the function of this area. This is the neuroplasticity, ability of the brain to take the function of the nearby area. Then there will be collateral sprouting. I will finish in another few minutes, and there will be unmasking of the new pathways. There are many pathways which are not utilized by the body. The patient may have new pathways. Next, please. Next. Next. So you have an occupational therapist in your team whose responsibility will be next to train the arm for the ADL activity, for vocational activity. This is a responsibility of the occupational therapist. Next. 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 The patient needs these things, the hand splint and the ankle foot orthosis. So this is the responsibility of the prosthetic orthotic technician in your team. Next. 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 The patient initially presented with aphasia. Next. So the patient will have the speech problem. Next. It will be addressed. The patient may have aphasia, dysarthria, and apraxia. Next. This will be managed by a speech pathologist or speech therapist who will teach the patient some oromotor therapy. Next. Melodic interventions. There are very many therapy approaches to improve the speech. Next. Then the patient may have, particularly when the patient has a brainstem stroke, he may have difficulty in swallowing. Next. So it is a role of the speech therapist to teach the patient the swallowing technique. Next. We have equipment called vital stimulation, where with the help of the electrode, we stimulate the pharyngeal muscles, neck muscles and pharyngeal muscles, with which the patient over the period of time will develop swallowing reflex. Next. Next. Our patient presented with the shoulder pain, the causes may be subluxation of the glenohumeral joint or shoulder hand syndrome or central thalamic pain. Next. This is how the shoulder pain is addressed. The shoulder chilling, analgesic exercises. Next. The complications of stroke, physiological deconditioning, bowel product incompetence, shoulder pain, and falls. Next. Our patient presented with the spasticity. When we assess the spasticity through modified Ashworth scale, he has spasticity in the following muscles. Next. 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 So spasticity is addressed by the following drugs. Commonly we use baclofen from 10 to 1080 milligram or diazepam 4 to 60 milligram. Next. Next. Okay, this all the palliative care physician must be aware. The acronym FAST. The acronym FAST stands for facial weakness, arm trip. Ask the patient to put out the hand. The patient may not hold the limb. It will trip. It will fall off. Arm trip. And S stands for speech disorders. Facial weakness, arm trip, speech disorder. Then T stands for the time to act. Immediately shift the patient to the center where they will thrombolyze the patient. Next. Okay. I will take 1 minute time. So this is an area where there is a blood supply to the brain is compromised. So the adjacent area highlighted in blue is called ischemic penumbra. Normally, 100 gram of brain tissue requires 50 ml of blood per minute. But here in the ischemic penumbra area, the blood supply will be 10 ml per kilogram. So we have to improve the blood supply through thrombolysis. Then this area, the neurons will survive. So there will be quick recovery. That's a ischemic penumbra. Ischemic penumbra means area closer to the thrombotic area. Next. 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 These are our center. Next. Next. We have a robotic hand therapy. Next. We have virtual reality, wonderful one. Next. Body weight supported treadmill. Next. Treadmill training. Next. It's a balance trainer. Next. Motomet theory, Motomet equipment. Next. Electrical stimulation to improve the muscle power. Next. To EMG feedback to know where the muscle, where the patient is feeling the contraction of the muscle. Next. 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 Right. So stroke rehabilitation is a teamwork. Always remember the acronym FAST. F stands for facial weakness. A stands for arm trip. S stands for slurring of speech. It's a time to act. Detailed assessment is important. Risk factor must be addressed so that the patient will not have the second stroke. Next. Thank you.
Thank you, sir. So I think we learned a lot, and I think we need to learn a lot because there are many things which we don't know. And I'm happy that the various types of bladder, that is something which every time confuses us because there are many names, atonic or hyperreflexic or that is one thing which I personally like in this presentation. I'm sure all of you might have confusion on that. And he actually told us taking a long time what happens and how it happens. And we need to learn many things. And each of, his way of teaching with specific topics, headings, and very systematic. So if you have one or two questions, you can ask.
Actually, the bladder rehabilitation is very interesting one, sir. I did not talk about the autonomous bladder. That will confuse you. That's why I deliberately did not discuss about autonomous bladder. I discuss about atonic bladder. I discuss about automatic bladder. We have another bladder called autonomous bladder. We will discuss on some other time. Thank you, Biju.
Sir, one thing about virtual reality, I just saw one slide. How helpful is it for rehabilitation of stroke patient?
Virtual reality, sir.
Yes, sir.
It's a wonderful tool, sir. Okay.
Yes, sir.
You ask the patient to, a stroke patient to move the limb. Patient may not be able to do. Okay. But on the screen, there will be a projection. There will be the hand will be moving. So patient will be synchronized. They will be attempting to move the limb. There are interesting tasks. You take the green ball to the green bucket, all images. So the patient has to move the limb from the ball to the bucket. So he may not be able to do immediately. For a period of time, he will do it. All virtual ball, virtual bucket. It's a wonderful tool. It's doing a good work in the rehabilitation.
So in fact, without knowing this, I used this in a patient who was quadriplegic, who was sent from abroad, and he was totally paralyzed when he came to us. So I used a virtual reality console for this patient. Within a matter of 2 weeks, he was able to move all the limbs, and he was rehabilitated much better than what he was ever before. So it was very encouraging. That's why I asked.
Patients love doing this virtual reality. So like a child, they will do.
It's very highly motivating for them. Thank you.
So good luck.
Okay.
Good luck for every one of you who are doing the fellowship. Good luck for you. I repeat my statement before I close again. If somebody wants to learn palliative medicine, you have to learn from Dr. Sunil Kumar.
I think no, thank you for the compliments. But we have to wind up the session,
Yes,
and I would advise all of you to go and read. We have to learn a lot from this session, and I think we have to read at least 5 times to get at least 60-70% of what he taught us. But all these are very important topics, and we see a lot of paraplegics, hemiplegics, and it is very common to have osteoarthritis. So that's why this topic has been selected. And thank you, sir, for a wonderful session. And we hope to see you another time.
okay. Thank you very much, and good luck to every one of you.
Thank you, sir.
Right. Namaste.
Thank you, Dr. Ramamoorthy, and realizing that we have far exceeded our time.
Sorry about it. Sorry about it.
No worries, sir, no worries.
So when
It is
you
actually
discuss,
a learning. So
see, when we discuss the basics, I feel basics are very important.
so
Let's
true,
get to
sir,
the brain is important. They must know what is middle cerebral artery. They must know what is the anterior cerebral artery, what is posterior cerebral artery. Right. Thank you very much.
Reply to your thing has come in the chat. Time was not enough for Dr. Biju. Yes, of course, we do understand that. So with a reminder that tomorrow also we'll be having a session from 7 to 8:30 p.m. as per the schedule. This is Sri Priya, along with Dr. Ramamoorthy and Dr. Sunil Kumar, signing off from the Pallium India's presentation desk. See you tomorrow. Till then, everyone take care. Keep spreading happiness. Bye-bye.
Bye now.